Chapter 23, which is endocrine disorders. In Chapter 23, we're going to cover probably some of the most dramatic emergency that we can make a very, dramatic difference in, that being the hypoglycemic patient. But we'll also cover some of the other issues that arise with hormones and that general system of internal secretion. So there's not a lot of things that become acutely emergent from the endocrine system besides diabetes. However, that being as prevalent as it is, it certainly seems like the endocrine disorders are a huge issue, but it's really only one of them. So we'll cover in this chapter, not terribly long chapter, diabetes as well as a few of those others. As with all the chapters, simply watching and listening to the lecture does not substitute for reading and studying the chapter. So if you have not done that, do so at your earliest convenience. So again, the AEMT will apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely ill patient. Your objectives you can find on pages 590 and 591 in your text. All right, so the endocrine system is the glands that secrete those chemical messengers called hormones. And hormones affect the individual body cells to regulate those body functions. Some of the hormones actually target other tissues in order to tell those tissues to secrete some different hormones to do something else. That mainly occurs between the hypothalamus and the pituitary gland in the brain. Mainly the hypothalamus just sends out a lot of orders to the pituitary gland, and the pituitary gland then turns around and relays those messages on via another set of hormones. But so sometimes it's a very complex and complicated, convoluted way that some of these messages get dispatched. The endocrine system obviously has a very crucial role in maintaining homeostasis. Part of the endocrine system, I guess, that we need to that we've been talking about for a long time here has been the adrenal glands, and we talk about the sympathomimetic catecholamines of epinephrine and norepinephrine. That is actually part of the hormone or the endocrine system. But we've talked about it in everything because it has a hand in it all. So even when we have a diabetic reaction, our body gets some sympathetic stimulation to try to give it a last-ditch kick. So there's constantly a balance going on between sympathetic and parasympathetic. And you may be thinking, well, that's nervous system. Well, that's very true. It is a nervous system. But the nervous system influences the endocrine system and uses a number of the endocrine neurotransmitters, epi and norepi, to do its work. So patients with endocrine disorders don't respond well to stress and stressors. So people who have endocrine issues, if they're incredibly stressed, tend to go into some crisis modes. Okay, so here's the main structures of our endocrine system. So a pretty good look at it. We look at the pineal gland, the hypothalamus, the pituitary gland, those really being a lot of controllers up there. And then we also have the parathyroids and the thyroid in the neck, the thymus gland, which is just above your heart, around your structures in the mediastinum. And then we have the adrenal glands, the pancreas, and then the gonads. In this case, they show the ovaries, but in the male, of course, that would be the testicles, or the testes. So releasing hormones act on other endocrine glands. So like I mentioned, the hypothalamus does a lot of sitting up there at the top, just dispatching messages to other places to go do something else. So we also have inhibiting hormones that act to decrease in action. So we have stimulating hormones and we have inhibiting hormones. So they're always kind of in a balance or a counterbalance. Only the cells with the receptor specific for that hormone will be affected by the presence of the hormone. So not all cells respond to all hormones. So here's a vast majority of our hormones are regulated by a negative feedback loop. So in this case, we have the hypothalamus, and then it's releasing a hormone to the pituitary gland, or a stimulating hormone actually. And that stimulating hormone tells the anterior pituitary gland to secrete something, and it secretes something, we'll say thyroid stimulating hormone. And then the thyroid is then stimulated and it does its thing, and then the body now starts to say, oh, well, we have too much of that. So then it starts to flip the switch and say, let's now turn on the thyroid inhibiting hormone. So it kind of has this it's constantly watching it and trying to play with the chemistry. So a lot of that secretion is regulated by negative feedback. So if the body has low sugar, a hormone gets dispatched to go create some more sugar. So the body gets low, the glucagon gets released. Glucagon goes to the pancreas. It releases the stored glycogen and turns that through the process of glycogenolysis, turns that into a usable form of glucose for the body. The body then starts to see, oh, well, now I have too much sugar floating around because you just ate a giant meal. So now what am I going to do about that? Well, it's going to dispatch insulin. Insulin's going to take and use up some of that sugar immediately with the cells, and other parts it's going to start to store some sugar in the form of glycogen in the liver. So, good examples there. The endocrine gland receives this message. It's either stimulated or inhibited by a composition of extracellular fluid or by the hormones from other endocrine glands. Now, some of our glands actually have endocrine and exocrine functions. Endocrine is generally chemical mediators that float through the body, whereas exocrine is there's fluids released. So, and the control of the release from the neurotransmitters of the neurons. So a few of the selected endocrine functions, you can find these in the chart on page 594 in your text. So the hypothalamus is stimulated by the autonomic nervous system, and it releases a number of hormones. Look at that. There's a giant number of them there. Between the growth hormone releasing hormones, somatostatin, which is growth hormone inhibiting hormone. We have corticotropin releasing hormone, thyrotropin releasing hormone, gonadotropic releasing hormone, and prolactin releasing and inhibiting hormones. So, and it's going to target mostly the pituitary gland. It aims mostly at the pituitary gland to tell it to do some other things, to stimulate or inhibit other functions. So then we move down to the anterior pituitary gland, and the anterior pituitary gets like I said, most of its stimulus from the hypothalamus, and then some of the other various hormones it monitors and says, okay, we need more or less. So the anterior pituitary will release growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. So growth hormone affects all the cells, makes them grow. ACTH, or adrenocorticotropic, aims at the adrenal cortices, or the cortex. The TSH works on the thyroid gland, FSH and LH work on the ovaries and the testes, and prolactin on the mammary glands. So when a woman is preparing to lactate to feed her child, it's from the release of prolactin. The posterior pituitary hormone also pituitary gland also gains stimulation from the hypothalamus, and it's responsible really for the antidiuretic hormone and oxytocin. Antidiuretic hormone works on the kidneys, and it's the opposite of a diuretic. So in the cardiac chapter, we talked diuretics have you get rid of urine, have you get rid of excess water in the form of urine. Antidiuretic then would be the opposite. It tells you to keep your water. So, and oxytocin, it works on the mammary, the uterine, and other smooth muscle tissues. Oxytocin is the hormone that really begins the process of labor. So when women go in to have labor induced, they receive oxytocin. Also, occasionally we give oxytocin postpartum to help a woman's uterus contract to help it stop the bleeding. The thyroid hormone is stimulated by the TSH and the calcium level. So TSH comes down from the pituitary gland. Calcium level is just constantly being monitored through the thyroid. It will release T3, T4, and calcitonin. T3 and T4. T3 is, they're both very long terms. I was going to see if I can find it for you guys to highlight. Maybe they don't have it in here. I thought they had it. No, they don't. Triiodoxidine and thyroxine. Those are the thyroid hormones, and they really are responsible for a lot of your metabolism. So increasing cellular metabolism. People who have hypothyroidism will have low metabolism. They're typically low energy, typically a little heavier set, slower moving. Hyperthyroidism is the other side of that. Calcitonin, it stimulates the bones to increase calcium uptake. So calcitonin says store calcium. Well, one that they don't have listed on here is actually from the parathyroid gland. Parathyroid glands sit on the back side of the thyroid. They're four little pea-shaped, little itty-bitty tiny glands on the back there. And they actually work the other side. So they tell the body, go rob, parathyroid hormone says go and rob some of the calcium from the bones. So it says don't have enough calcium to make our muscles work. Where are we going to get it? Go steal some from the bones. The pancreas, it watches levels of the glucose and different amino acids, and it secretes at least 3 hormones: glucagon, insulin, and somatostatin. It also has an exocrine aspect to it, where it actually secretes pancreatic juices in there to help with the digestion. We know that glucagon promotes the increase of glucose level through glycogenolysis in the liver, steals it from the glycogen stores. The insulin affects all of our cells, and it promotes glucose uptake, protein and glycogen and fat synthesis, and then as well as storage. And then somatostatin acts locally to inhibit both the alpha and beta cells. So somatostatin tells the pancreas no glucagon, no insulin. So it's kind of the gatekeeper of both of them. The adrenal cortex is stimulated by ACTH, so from the pituitary gland. The adrenal cortex has most of our steroids. So the glucocorticoids, the mineralocorticoids, and then the testosterones, estrogens, and progesterones. So the majority of the steroids in our body that have a lot to do with sex hormones, as well as maintaining fluid balance, and somewhat our growth and our inflammatory response come from the adrenal cortex. So glucocorticoids such as cortisol, it increases blood glucose. That's commonly called on late night television the stress hormone. So when you're stressed, you're secreting cortisol, you're releasing blood glucose. It's supposed to also help with suppressing inflammation, and then your immune response. Mineralocorticoids mainly have to do with fluid balance and salts, and then of course your sex hormones. A lot have to do with your secondary sex characteristics. The adrenal medulla, it gets most of its stimulus from the sympathetic nervous system, and its main hormones are epinephrine and norepi. You know, epi acts on the muscle, the liver, and the cardiovascular system to stimulate fight or flight, and norepi causes vasoconstriction. So the three main endocrine functions of the hypothalamus: control the pituitary gland through the secretion of releasing and inhibiting hormones, so on and off buttons, making two hormones that are released by the pituitary gland, so posterior pituitary gland, so it actually creates them and sends them down. And then the nervous stimulation of the medulla of the adrenal glands. So through the process of it dispatching information down through the sympathetic nervous system, it dispatches the norepi and epi. So we'll kind of get here into the meat and potatoes of what we're looking at here. We're looking at really blood glucose being our major player in this chapter. So glucose, of course, our simple carbohydrate or a sugar. It is our preferred energy source. It's the easiest one for us to use. And remember, while in the presence of oxygen, it is a very efficient form of creating energy. So normal cellular metabolism, it requires that steady source of glucose. We constantly have to have sugar, we constantly have to have oxygen, and we constantly have to have water. Otherwise, if we don't have all three of those major building blocks of life, things don't function well. So the primary storage for glycogen, again, is in the liver. You don't always have huge amounts of it. Sometimes you deplete your source rather quickly, particularly if you're a little skinny person. And then without glucose, the cells have to start using the fats for energy, and they start to basically kind of cannibalize the body. So without that constant supply, the brain does not function. The good thing about that, remember that the brain does not require insulin to get glucose, but if the glucose levels drop to a very, very low level, it's just not available to the brain. Hypoglycemia is a life-threatening emergency. So when your sugar is so low, it is a life-threatening emergency. Hyperglycemia is usually a longer onset process. Hypoglycemia is very, very quick. So the endocrine function of the pancreas takes place in the islets of Langerhans. I think that sounds really cool. But you can see a picture of that on 595, or it's actually in our next slide. But the islets of Langerhans is the endocrine tissue of the pancreas. There's also the pancreatic acini, which is the exocrine tissue. So when it creates the pancreatic juices that helps to digest more of the fats and some of the carbohydrates and break those apart. That's what comes from the exocrine tissue, or the acini there. You have alpha, beta, and delta cells within the islets of Langerhans. Those are the different cells that create the three major hormones, the somatostatin, insulin, and glucagon. So, and those levels of glucagon and insulin, they have to always kind of be in a balance to meet our metabolic needs. So it's constantly looking, constantly checking to say, okay, what do I need? What's the major goal that we're trying to accomplish here? Do we need lots of sugar, or are we in a reserve mode? There's actually a good little chart on 595 in your text up at the top there. Kind of helps you look at the differences between insulin and glucagon, where insulin is the dominant hormone. when blood glucose is high, glucagon is when it's low. Insulin targets all cells, whereas glucagon targets mostly the liver, and it tells the liver to increase production. Insulin tells the liver to increase production of glycogen, and then proteins, fats, and storage, whereas glucagon goes and it tells the liver, let's increase the amount of free glucose through the process of glycogenolysis by robbing the glycogen. And insulin says to the liver in fats, it says let's increase production of those fats, whereas the liver in glucagon says let's create more glucose by breaking down the fat. So, pancreas and blood glucose levels. Where is the glucose secreted and where is the insulin secreted? We've got the alpha cells that secrete glucagon and the beta cells that secrete insulin. And then the delta cells is the somatostatin. So, thyroid gland hormones control the rate of our metabolism. So in a way, they're all kind of working together, because if you have a high metabolism, you're using sugars. So you're probably going to see insulin first off after a person eats, but then you probably have quite a bit of glucagon being secreted to constantly keep up with that high demand from the high metabolism. And then our adrenal medullary hormones, medullary, are the epi and the norepi, and they're secreted in response to that sympathetic nervous system stimulation. And then we also have the mineralocorticoids to help control electrolyte balance. So those are going to, as we need more salts or less salts, they're involved, as well as our water. We also see glucocorticoids that affect the glucose metabolism, and then the androgens, which are the sex hormones or the sex steroids, that are secreted from the adrenal cortex. Okay, so reasons to suspect a diabetic emergency. History from a bystander, presence of a medical identification, clues from the scene size up. So how can we confirm a diabetic emergency? Hopefully we have the ability to check a blood sugar. Glucometry would be a wonderful tool here. So hopefully we have a glucometer, or at least some method of checking a blood sugar. So when we talk about history from bystanders, somebody tells you they're diabetic, somebody tells you they were alert and suddenly became unresponsive. Presence of medical ID jewelry, so maybe we have a medic alert, maybe there's a vial of life in the fridge, something along those lines. Clues from the scene size up. We're looking at things like, do we find insulin syringes? Do we find vials of insulin? Do we find medications such as metformin, glyburide, and whatnot? So we've got to be looking around for those things, sharps containers, and so on and so forth. Confirming the diabetic emergency, you look for your signs and symptoms and try to use glucometry whenever possible. So patients with hypoglycemia can be agitated, they can be confused, they can be combative. Sometimes they're just plain unresponsive. Hyperthyroid patients are generally excessively hot, even in a cool environment. Then determine the level of responsiveness using ABPU. So they may be hypoglycemic as a result of their hyperthyroidism. So their thyroid might be kicking in and it's robbing their sugars. So somebody who would be a diabetic and have issues with hyperthyroidism could potentially be a very delicate balance. So a history of endocrine problems can be a key to determining and correcting the underlying problem. However, sometimes we just don't have all that ahead of time. Sometimes it's really a crapshoot. Sometimes people can't tell us that they have issue with, say, hyperthyroidism or problems with their adrenal glands. So some causes of altered mental status. Many of these probably could be seen in endocrine emergencies. You can use the mnemonic AEIOU TIPS, so your vowels TIPS. A for acidosis, including diabetic ketoacidosis and or alcohol. E for epilepsy. Hypoglycemia may result in seizures. I for infection. Diabetics and patients with adrenal disease are prone to infections because those steroids are used to help with inflammation. Overdose, maybe an insulin overdose, could be an anti-hyperglycemic agent overdose. Uremia, kidney failure. Diabetics are highly prone to kidney failure. Trauma, tumors, toxins. Insulin, too much or too little. Psychosis and poisoning. And stroke, shocks, and seizures. So diabetics are at higher risk for stroke. So really many of these kind of come into play with our diabetic emergencies. Now, certainly we may have other emergencies that aren't endocrine that cause altered mental status. Simple things such as hypoxia come into play as well. So we might have a hypoxic patient that has this altered mental status. We may have the person that, trauma, tumor, toxins, those all kind of back that up. All right, so many patients with endocrine disorders have already been diagnosed, and taking a look for some of their medications can give us some great clues to what's going on. So things that have thior in them are generally for people with thyroid issues. Levothyroxine or Synthroid, that is the thyroid hormone. It is used to treat hypothyroidism. Overdoses may cause signs and symptoms of hyperthyroidism. Another thing to consider, sometimes people actually had hyperthyroidism, and through their treatment for their hyperthyroidism end up getting hypothyroidism because they have to kill off part of their thyroid gland. So granted, at that point they now switch from being a hyperthyroidism patient to a hypothyroidism patient. They're very likely to be on that. Methimazole or Tapazole, it's used to treat hyperthyroidism. It blocks a lot of that thyroid hormone synthesis, and it can indicate Graves' disease. So some people that have hyperthyroidism that are basically in overdrive with their hormones and their metabolism, you might see that them to be on Tapazole. The various steroids, prednisone, prednisolone, dexamethasone, cortisone, so all the sones or ones, loans, those corticosteroids and mineral can be used to treat the various issues, whether it's an inflammatory problem. People who have a lot of inflammation usually need some steroids, particularly if their body's not able to create those. You may also have the glucocorticoids, in which people are not able to control their, the mineral corticoids, which people are not able to control their salts and waters very well. So people that have lots of steroids can develop something called Cushing's syndrome. And sudden withdrawal actually will then turn into an adrenal insufficiency. Insulin, Humulin, Humulin, Lispro, others. There's all kinds of variations. There's different mixtures. There's 70-30, 60-40, 75-25. Regular, NPH, Lenti, Similente, Ultralente. There's so many different types of insulin out there right now. It is a replacement insulin that patients take via injection to help them uptake their glucose. A little bit too much goes a long ways and can actually put them into hypoglycemia very, very quickly. And then we have some drugs for type 2 diabetics. So these are referred to as oral anti-hyperglycemic medications. There are only about 1 billion of these on the market. A good number of them there are listed. Tolbutamide, which is Oronase, chloropropamide, which is diabinase, metformin or glucophage, glyburide, micronase, glipizide, glucotrol, rosiglitazone, which is Avandia, sitagliptin, Januvia, and then a couple of other injectables like xenatide, which is Byetta. You don't see that one very often. But these are not insulin. They're not oral insulin. What they actually do is the mechanisms will increase the insulin production or make the body more receptive to the insulin the patient is making. People who are on injectable insulin are creating really basically no insulin, if not absolutely no insulin. Whereas people on these type 2 drugs are creating some insulin. Their body is either resistant to it or they just don't create enough. All right, so understand our basic functions of the glands. Most often in the endocrine emergencies, immediate problems may be caused by excess or insufficient amounts of one or more hormones, and these endocrine disorders increase the risk for many other illnesses. Great examples of people who have issues with their steroids is they're highly susceptible to other illnesses taking them down because they don't have quite the abilities to fight those. So if given, oral glucose, 50% dextrose, and glucagon are used to treat hypoglycemia, and then we have to reevaluate the patient's blood glucose after that. So we're going to want to continuously watch that because we're going to make sure that if we've treated them, we're getting them back, they're waking up, that we don't have them slip backwards again. And in most places, we're going to make sure we have a second vial or amp of D50 to give them should we have a relapse. So our diabetics and diabetic emergencies, diabetes mellitus. There are other types of diabetes. The biggest main other one is diabetes insipidus, which is actually a problem with maintaining your fluids. Diabetes mellitus, when you actually translate that, that means diabetes is to flow through, and mellitus is honey sweet. So yes, the way that they first determined this was somebody had to taste the king's pee, and it was sweet, it was sticky. Diabetics have large amounts of sugar in their urine, so and diabetics pee a lot. So diabetes mellitus is a disease of glucose regulation. It is an insulin problem, not a glucose problem. Sometimes we make it a glucose problem because we misuse insulin. So type 1 diabetes, the insulin-dependent diabetes, or what we formerly referred to as juvenile onset, is destruction of those beta cells of the pancreas, and it results in insufficient insulin production. So these people are insulin dependent. They require supplemental insulin. Whereas type 2 diabetes, formerly called adult onset, it's abbreviated NIDDM, usually occurs in the middle-aged, typically adult or obese individuals, and usually can be controlled with oral medications. So this is a problem in which they just don't have enough. It's insufficient or the body is resistant. So to compare the two, type 1, sometimes called insulin-dependent diabetes mellitus, IDDM, or juvenile onset, whereas type 2 is NIDDM, NIDM, non-insulin dependent, or adult onset. Type 1 is a autoimmune, where the body actually attacks its own cells, destroys its own beta cells, and it wipes out insulin production. Whereas type 2, the amount of insulin that is produced is just reduced, or the body has resistance. Both these generally are genetic, have genetic factors, genetic predispositions. Type 2 diabetics are typically obese, or at one time were. Hypoglycemia may occur when the amount of insulin administered is too great for the amount of calories ingested for the type 1. And type 2 may occur when the dose of anti-hyperglycemic medication is too great for the amount of calories ingested. So basically the same basic cause. When do they develop hyperglycemia? Most type 1s will develop what's called DKA, diabetic ketoacidosis, and this occurs undiagnosed or poorly controlled diabetics, or in response to an increased glucose production from stress, such as surgery, infection, illness, or trauma. Most type 2s actually will develop a syndrome called NKHC. This is also sometimes called HHNK, HHNC, honk. This can occur in poorly controlled diabetics or in response to the same basic things. These people usually will have much, much higher blood glucoses. So DKA is probably somewhere in the 200 to 600 range, whereas NKHC is 600 plus. Complications are essentially the same. If they are poorly controlled, they don't take care of themselves, blindness, cardiovascular disease, stroke, kidney failure, amputation, neuropathies, peripheral vascular disease, non-healing wounds, gangrene. Sounds lovely, doesn't it? And management, diet control, weight loss, exercise, watching their blood glucose, taking their medications as necessary. Those people who choose to stick closely to their doctor's advice usually end up doing okay, don't end up with too many problems. Currently it is incurable outside of occasionally with some transplants they'll get some near remission. Acute diabetic emergencies that we typically deal with, the most common one is hypoglycemia. That one is dangerously low. It is quick onset. The other ones that we deal with are hyperglycemic events. They're slower onset. They typically, patient has some heads up time before they run into these issues. Hyperglycemia, the amount of insulin present is insufficient for the amount of glucose. So there's glucose just running around in the body, but it can't get into the cells because there's no insulin there. They may develop a non-ketotic hyperosmolar coma or a diabetic ketoacidosis. So let's compare those a little bit here. DKA, and we've talked about who commonly see those. The cause of DKA is typically the inadequate insulin to allow glucose to enter to create metabolism, or to maintain metabolism, and it results in the body using up some of its fats for energy. Whereas the NKHC, the amount of insulin allows some glucose in for metabolism, but it can't lower the blood glucose to normal. So the body continues to kind of chug along there, but the sugar just continues to rise and rise and rise. The consequences for hyperglycemia tends to lead to dehydration. Actually, both of them lead to dehydration. A lot of osmotic diuresis, so they're peeing a ton and trying to remove as much sugar as they can through urination. They also lose tons of electrolytes when they're urinating because salts and waters get along, are best friends. When the DKA patient uses up its fats, they create ketones as a byproduct. Ketones, similar to acetone, it's an ugly acidic substance that gets into the blood. The NKHC person does not. develop ketones. They don't have the same sort of symptoms. So dehydration, acidosis, and these electrolyte abnormalities lead to them becoming an altered mental status. They very commonly will have Kussmaul's respirations in an attempt to compensate for the metabolic acidosis. Keep that in mind. The dehydration and electrolyte abnormalities will lead to the altered mental status, and then the increased risk of cardiac dysrhythmias in the NKHC person. DKA, hours to days, and that's most commonly more like days, and it may be preceded by some sort of a traumatic event, whereas the NKHC person, it definitely takes several days, sometimes even weeks to get there. Signs or symptoms, they're both gradual onset. They will have slower onset altered mental status as opposed to our hypoglycemic patient, which has almost, in just minutes, goes from completely alert to unresponsive. They're both going to be warm. They're going to have dry skin, poor skin turgor. They can have orthostatic hypotension. They're both typically going to be tachycardic, have polyuria, meaning they're going to pee a lot, polydipsia, meaning they're very thirsty, and polyphagia, meaning they're hungry, because their body's not getting the signal that they actually have the sugar there. Kussmaul's respirations in the DKA patient, they may have a sweet acetone odor on their breath, complaints of abdominal pain, and then nausea and vomiting. The patient with the NKHC, they may have nausea and vomiting. They don't typically have the abdominal pain, and they won't have the Kussmaul's or the acetone breath because they don't create the ketones. Sugars 300 to 500 or 600 for the DKA patient, 600 plus, even over 1,000 for the NKHC. They're treated the same way. Management of the ABCs, IV dehydration or IV rehydration. And when you're doing IV rehydration, don't just open it up and run it wide open. It took them days to get dehydrated. It's going to take them days to get rehydrated. If you just start flooding them with fluids, if they're not hypotensive, all you're doing, you're just running through them as fast as possible. They're not getting the benefits. So, running it in maybe 150, 200 cc's an hour helps them actually get some benefit from that. Okay, signs of the untreated or inadequately controlled diabetic, sometimes undiagnosed. Polyphagia, excessive hunger. Cells are starving. The undiagnosed or the poorly controlled diabetic 1 is typically thin and malnourished. They're not able to pick up and use the sugars like they need to. Polyuria, the excess glucose molecules, they continue to be in the blood. The body can't use them. The kidney then says, well, let's get rid of them. So, boom, flushes them out. And because there's so much extra sugar there, the body continues to just constantly secrete it with urine. Polydipsia, this is we've urinated and urinated and urinated, so we're getting dehydrated, so now the body says, oh, I need to rehydrate, so drink. So in our diabetic ketoacidosis, the fatty acids are inefficient fuels, produce a lot less energy, a lot more waste. That waste, one of the major wastes is the ketones. Ketones is an acid, and that changes the body's pH, decreases the pH to make it much more acidic. So as the body has to break down the fats, it's unable to use them quite as efficiently. So there's a lot more crap. Kussmaul's respiration. So Kussmaul's respiration is the body's attempt to compensate, because body says if I get rid of more carbon dioxide, which is an acid, then I can offset the acid that's building up in my body from the ketones. So it's attempt to compensate or to get rid of excess acids. And so hyperventilation, hyper and fast and deep respirations helps to blow that excess off. So the AEMT's treatment for DKA is going to be administering large volumes of isotonic crystalloid fluids to begin treatment for rehydration. But like I said, you can run it through them. You can run a liter of fluid through them in 30 minutes. You're not going to gain much benefit from it. So a little bit more reserved approach may be a better approach, unless they're hypotensive, of course. So check their lung sounds. Be watching lung sounds. People who are diabetics commonly have other issues, so they could have some congestive heart failure. If they have CHF, then in those cases we got to be careful that we don't flood them out with too much fluid. So people who are in DKA or HNK, I still call it HHNK, are both very, very ill. And in fact, people with the NHK or NKHC often have fatal illness. So the NKHC, much more serious, much higher mortality rate, can be up to 90% actually. Signs and symptoms are very similar, just don't have the Kussmaul respirations. The other key finding is when you check the sugar, your sugars will often say high, because most glucometers today are reading upwards to 500 or 600. Anything above that, it'll say high. So if it's registering high on your glucose monitor, you're going to have to know what your monitor reads, what the range is. If your glucose monitor is reading high, it's very possible that your patient, if they don't have Kussmaul respirations, is in NKHC. So hypoglycemia are more dramatic and probably one of our favorite emergencies to run on is the hypoglycemic patient. We usually can make this a fairly quick fix. It rarely occurs in a non-diabetic adult patient. Usually they have to have had too much of their medication to really throw them off. It is a very sudden onset, talking minutes. Their altered mental status is the most important sign. It can also lead to seizures, and this is which came first, the chicken or the egg. We have, did the seizures cause the hypoglycemia, or did the hypoglycemia cause the seizures? So it's an altered mental status. Altered mental statuses we check blood sugars on. So check the blood glucose with an altered mental status. If we have hypoglycemia, try to fix it. We have easy ways to fix that. So signs and symptoms of hypoglycemia: sudden onset of altered mental status or bizarre behavior. They can be anywhere from just unresponsive to the sweetest person in the world actually turns into the biggest butthole ninja fighter that wants to kill everybody when their sugar gets low. They may be very irritable, weak, loss of coordination, look like they're drunk basically. Headaches, weak rapid pulses, pale, cool, diaphoretic skin. The body is really under fire because it doesn't have the ability to make the energy that it really needs. Occasionally we also have the diabetic who chooses to refuse transport. And in those cases, when we have the refusals, once their mental status is returned to normal, we really can't transport him without his consent. So you're going to need to be very, very explicit with this person. Let him know what the benefits are, what are the risks, and then provided that he or she decides to not go, we need to make sure that we have a plan in place so we don't have another drop in blood sugar. So we have them eat a meal or a snack with adequate protein. So cheeses, lunch meats, peanut butters, those are good protein sources. Proteins are a longer acting sugar as opposed to the quick sugars that we might get from, say, jelly or a pack of sugar or a candy bar. Those are quick sources of sugar that will quickly be used up. So we make sure that they have a meal or a snack, and then advise them, call us back if any other issues appear. Document the heck out of that. It's a no transport situation. Should something come up, this guy has another hypoglycemic event at home, he dies, nobody finds him, you're going to get nailed to the cross. So you're going to need to document. All right, so you will care for patients whose immediate problem is not a diabetic emergency, but the conditions related to a complication of diabetes. So what are some common complications of both types of diabetes? So we talked about that before, that things such as problems with circulation, they're much more higher risk for strokes and heart attacks, problems with their eyes, so on and so forth. So real quickly, draw your attention to 602 in your text. That second column really does a fairly good job of discussing the treatment of hypoglycemia. Patients do the simplest things first. So things such as, if they're alert and able to maintain their own airway, oral glucose is fine. You don't have to give them D50 just because you're an advanced EMT. So if you can get their sugar up without sticking a needle in their arm, that's actually the best thing for them. It's the least risk. You have to, though, weigh whether or not this person can actually maintain their own maintain their own airway. So when we are treating the patient, we don't want to turn our diabetic patient into a choking patient. So if we're unable to do an oral form of glucose, then we need to then consider the IV route. So patients with the decreased level of consciousness that can't control their own airway, we've got a blood sugar lower than, in most systems say lower than 70. Some places it's 60, some places it's 80. But we have the patient with a lower than normal. The other thing about that is, I got to segue off that for a second, is everybody's different. Some people function fine with a blood sugar of 60, while some people are nearly unresponsive for the blood sugar of 60. So hopefully somebody's around that knows this diabetic that can kind of help you out with that. So, but anyway, getting back to IV glucose, you know, if we've got a patient that maybe has a blood sugar of 30 or 40, you may want to give them only half the AMP D50. So remember, we've got 50 milliliters with 25 grams in it. We may choose to give them 12.5 grams or only 25 milliliters. You need to have a good IV, usually at least an 18 gauge catheter, one that flows very well with the fluid. We need to make sure that the sugar gets into their veins with no problems and gets put into the system and circulated. If that IV does not flow well, don't give D50 through it. It will actually cause their tissue to become necrotic. If it's extravasated, there's a good term in the text there, extravasated, that means it, if the D50 gets outside the vein, remember it is hypertonic. It will rob all the fluid from around it and kill off the associated skin, or adjacent skin, I should say. If we can't do the oral route, we can't do the IV route, then we could consider doing the IM route with 1 milligram or 1 unit, happens to be the same, of glucagon. Now, if you gave half an AMP D50 and it doesn't work for this person to bring them up, you can give them another half an AMP D50. Maybe sometimes you even need to give them a second AMP D50. With glucagon, it's usually kind of a one and done sort of thing, and it's kind of your last ditch. Do not do both if you don't have to. Glucagon should be reserved for those patients that you can't get an IV on. It takes longer, it's not as efficient, and it doesn't always do quite as good of a job. And remember, they have to have a glycogen store. So if they're itty-bitty tiny and you've been there and given them glucagon 4 times this week, they may not have much of a glucagon store. It may have all been robbed. So remember that the glucagon is typically IM. You have to reconstitute that. So you got to mix the liquid with the powder, mix it up, draw it back up, and then inject it into the patient. Thyroid disorder. So this person has a goiter, meaning that their thyroid has swelled ridiculously. This is as a result generally of hyperthyroidism. However, it can also be sometimes seen in the hypothyroid patient as well. So the goiter, that's an incredibly large thyroid gland. So, and in hyperthyroidism, they typically have increased metabolism. They're dropping weight like it's going out of style. They have heat intolerance and other problems. One of the common things that we'll see is something called exophthalmos, where their eyes bug out. It's not a great picture in the book. There's much better pictures of exophthalmos on the internet. But these are eyes that dang near just are bulging completely out of their sockets. And there are occasional cases in which patient with Graves' disease, which is the worst form of a hyperthyroidism or thyroid storm, their eyeball actually will come out of the socket and they'll have to go in and have their eyeball put back in. So hypothyroidism, on the other hand, these are puffy, thick, heavy patients. They have cold intolerance, and in severe cases they can have a myxedema coma. So basically it's either you can tell, I mean, everybody's pretty common sense that, you know, when your thyroid is in overdrive, your metabolism is in overdrive. So you're burning, whereas opposed to if you're hypothyroid, you're just not using anything, and you're just kind of existing. So goiter is the name of that enlarged thyroid gland. There's that picture of exophthalmos. Like I said, this isn't the greatest picture of it. I would do a Google search, Google image search for exophthalmos or Graves' disease, and you'll come up with some good ones. So Graves' disease is a form of hyperthyroidism. It's an autoimmune disorder. There's a very high production of thyroid hormone, and exophthalmos is one of the primary signs that we see of that. They may also have a thyroid storm or a thyrotoxicosis, in which the thyrotoxicosis is the sympathetic nervous system is really kind of kicked into overdrive, so they have very high levels of epi running through their system. They're tachycardic, hypertensive, and actually can lead into heart failure. Hypothyroidism, usually it's an iodine deficiency. They may have had a surgical removal of their thyroid gland. The thyroid uses iodine for most of its functions. They may have also had radiation therapy at some point in their life, and it killed off their thyroid gland. And in fact, sometimes they'll use a radioactive version of iodine to kill your thyroid gland if you have a hyperthyroidism. Sometimes it will also pop up through autoimmune, meaning the body attacks their own. It gets treated with supplemental administration of the different thyroid hormones, so the T3s and T4s. So usually they'll be on Synthroid for this. So examples of comparing hyper versus hypo. Hyperthyroidism typically will have the Graves' disease as a associated condition. They have a goiter. Remember, goiter can go either way, hyper or hypothyroidism. signs or symptoms of hyper, weight loss despite an enormous appetite, anxiety, intolerance to heat, diarrhea, palpitations, tachycardia, hypertension, non-pitting pretibial edema. So the front of their shins actually become kind of thickened. Whereas the hypothyroid patient, they have a lot of weight gain despite a decreased appetite. They have fatigue and lack of energy, lack of emotions, slowed mental functions. It's like they're in slow motion. So intolerance to the cold, myxedema in prolonged cases where they'll actually start to get some associated edema with around areas of their face and other areas of their body where they kind of get really puffy. And then emergencies for hyperthyroidism, we have thyroid toxicosis or thyroid storm. Like I said, they'll typically have tachycardia. They can have high fevers, high heart failure, vomiting, diarrhea, psychoses. Whereas the myxedema coma is accompanied with bradycardia, hypotension, respiratory depression, elevated capnometry readings, and severe hypothermia. So, I mean, they're polar opposites, really. So, yeah, we just touched on all those. So, what is the recommended treatment for hypothyroidism? So, for hypothyroidism, they're going to get a replacement hormone. If we have to deal with them, we're going to want to be cautious. We're going to give them some IV fluids if they're hypotensive, but be cautious that if we end up with any problems with fluid overload, and got to be careful not to make them hypothermic. So it's kind of a treat for shock sort of thing. The adrenal disorders. So this is long-term adrenal insufficiency. Usually this is the result of a damage to the adrenal cortex, the result of an autoimmune disease in many, many cases. Occasionally it's an infection or a trauma. Hypoperfusion would lead to decreased blood flow to the area, could start to cause some damage to those adrenal cortices. One of the things that we see pop up from time to time in the adrenal disorders is we have Addison's disease, and this is the adrenal insufficiency, and it will often give us a characteristic buffalo hump and edema above or periorbital edema, so where they would have very puffy eyelids, very moon-shaped faces, and you can also see some hirsutism, so she has increased hair growth. Cushing's syndrome, on the other hand, or I should say that's Addison syndrome. We'll get to that here in a second. Cushing's syndrome is from an overexposure to the glucocorticoids, so this all comes from the excess sugars that are floating around. Complications can be osteoporosis, hypertension, diabetes, muscle wasting, susceptibility to infection. So to kind of compare and contrast, Cushing's, this is excess adrenal cortical hormones due to glucocorticoid therapy, whereas Addison's is insufficient. So if too much adrenals is Cushing, causes you to have some Cushing's, and Addison's is insufficient. So it can be from a withdrawal of corticoid therapy. Typically associated Cushing's would be COPD, asthma, cancer, inflammatory conditions that requires them to have steroids, diabetes potentially. They're at higher risk for cardiovascular disease. Whereas Addison's, they have inability to respond to certain stressors such as infection, surgery, trauma. Cushing's, they have weight gain around the trunk, often thin extremities, a moon face, an accumulation of fat right up at the top between the shoulder blades called the buffalo hump. Very thin, easily bruised, torn skin, long wound healing, and development of facial hair in women, or hirsutism. Addison's disease, on the other hand, you get a hyperpigmentation, usually of the skin, gums, nail beds. They have chronic fatigue, weakness, and weight loss. And then in emergencies, we typically are going to see, in Cushing's, it's going to be other emergencies, MI, strokes, and whatnot. In Addison's, they may have an adrenal crisis or an Addisonian crisis, where they're going to end up with hypoglycemia, hypotension, cardiac dysrhythmias due to electrolyte disturbances. Because they were used to having that supplement, now the supplement is gone. Now, in summary, signs or symptoms are very general for many of the different endocrine disorders. In many cases, we need to rely on what we can get out of history from these people, as well as our scene clues. You need to have some knowledge of the endocrine system and its role in the homeostasis of the pathophysiology. Basically, many of the things that we're doing are really supportive care. ABCs, keep them warm, IVs for hydration for the hypoglycemic patients, oral glucose, IV glucose, or IM glucagon for the hyperglycemic patients, appropriate fluid therapy. Patients with thyroid problems can have temperature regulatory issues and be prepared to treat hyperthermia or hypothermia.